Good morning, students. We are today going to discuss about prolonged pregnancy. So, any pregnancy which has passed beyond the date of expected date of delivery is called as prolonged or post-dated pregnancy. A pregnancy continuing beyond 2 weeks of EDD is called as post-maturity or post-term pregnancy. So, any pregnancy which has passed the 40 weeks of gestation, that is 40 to 41 weeks, it is called as post-dated pregnancy, and after 42 weeks it is called as post-term pregnancy. Incidence usually, and on an average, the incidence of post-dated pregnancy is 10%. Etiology: the most common cause of post-dated pregnancy is first is wrong dates. Usually the patients are not sure about their LMP, which leads to very false diagnosis of post-dated pregnancy. And there is biological variability in the family. There can be a family history of post-dated pregnancy. Maternal factors are primiparity, previous history of prolonged pregnancy, history of sedentary habit, and elderly multipara. Fetal factors are congenital anomalies like anencephaly and fetal adrenal hypoplasia. In these cases, there is hypothalamic pituitary and adrenal axis dysfunction, which leads to absent release of corticotropin releasing hormone. So the initiation of labor is delayed in these cases. And placental factors are sulfatase deficiency. Placental sulfatase deficiency, there is decreased production of estrogen, so the oxytocin and prostaglandin receptors in the myometrium are decreased. So because of which there will be delayed initiation of labor. So how you will diagnose the post-dated pregnancy is, first we have to be sure about the gestational age. So for calculating the gestational age, the three important dates are the date of LMP, early ultrasound dating, and timing of intercourse. We can estimate the gestational age by clinical and by investigations. Clinically is by LMP and auscultation of fetal heart rate, usually in 17 to 20 weeks of gestation, and by the fundal height and feel of the head. In preterm babies, the head feels soft, whereas in terms it feels hard, and amount of liquor. In term and post-dated pregnancies, the amount of liquor, it starts decreasing, and cervical condition, towards the term the cervix can become soft, it becomes ripe. And by investigations are non-invasive and invasive. Non-invasive is by sonography. The first trimester sonography is by measuring the CRL. It is the most accurate, and if the dating scan, if the date in the first trimester scan is within 5 days of the LMP, we can take the LMP date as accurate. And second trimester dating is by BPD and femur length, but the variation in these dates will be of plus or minus 1 week. In third trimester scans, the date which we get, it is plus or minus 2 weeks. And by amniotic fluid volume, usually in postpartum pregnancies, the amniotic fluid volume, it decreases. And invasive are amniocentesis. We do for orange color cells and presence of phosphatidylglycerol, L by S ratio, lamellar body count, and saturated phosphatidylcholine. Pathophysiological changes. We know that amniotic fluid volume, it increases and reaches a peak by 38 weeks, and then later it starts decreasing. So after 40 weeks, it starts decreasing more rapidly. So this decline is because of decreased urine output by the fetus because of redistribution of fetal circulation and reduction in the renal perfusion of the fetus. And it doesn't only decrease in the volume, but it also becomes thick because of the vernix caseosa. Therefore, if there is any meconium passage by the fetus, there is high risk of meconium aspiration. An amniotic fluid estimated sonographically by estimating the 4-quadrant AFI or single deepest pocket. If the AFI is less than 8 cm or single deepest pocket is less than 2 cm, it is considered as a marker for intervention. Placental changes. After 38 weeks of gestation, in placenta there will be infarcts and calcifications. There will also be fibrinoid necrosis and atherosclerosis in decidual and chorionic blood vessels. These changes will increase with increase in the gestational age. So these are the changes which we see in the placenta with each gestational age. In the first trimester, this is the grade 0 placenta. This placenta, it will be homogeneous without any echogenic densities, and it has a very smooth chorionic plate. In grade 1 placenta, there will be slight indentations in the placenta, and there will be few scattered echogenic densities, but the basal layer will be clear in grade 1. Whereas in grade 2 placenta, the echogenic densities are seen in the basal layer, and the indentations, it will increase. We can see echogenic densities which are scattered within the placenta. And grade 3, it is a mature placenta. In this, the indentations are more. The placenta, it appears as cotyledons, and there are comma shaped densities, and there are acoustic shadows within the placenta. Complications. Maternal or there will be perineal trauma, increased operative interventions. There can be cervical tears, PPH, and postpartum infections. Because these all cervical tears and perineal trauma is because of increased weight in the baby, so that can lead to increased trauma during delivery. And fetal asphyxia and hypoxia. These can be because of cord compression and because of oligohydramnios and meconium aspiration, and there is also risk of shoulder dystocia and fetal trauma. And neonates is there is a high risk of chemical pneumonitis, atelectasis, and pulmonary hypertension. These are because of meconium aspiration. And there is hypoxia and respiratory failure. And in neonate, they are more prone for hypoglycemia and hypothermia, and polycythemia and post-maturity syndrome. In post-maturity syndrome, the babies, they look like an old man they have an old man appearance with wrinkled skin and long grown nails and stained with meconium. Management. So if the pregnancy has gone past dates, fetal surveillance we have to do. Usually it is recommended by ACOG from 41 to 42 to start from 41 weeks, but usually from 40 weeks we'll start the fetal surveillance. That is by twice weekly NSTs and sonography for Likert quantity and umbilical artery Doppler. Options for management are we can do expected management till spontaneous onset of labor, or we can induce the labor. But if we are choosing expected management, we have to do fetal surveillance with the twice weekly NSTs and Likert quantity sonography. Induction of labor. This has to be considered in cases with maternal complications like hypertension or diabetes, because in these cases already there will be decreased placental perfusion. So with increasing gestational age, there is more risk to the mother and to the fetus. And if there is any oligohydramnios and cases with the fetal growth restriction and advanced maternal age, and when there is suspected fetal compromise on fetal surveillance. Intrapartum care is usually these labors they are prolonged because of big baby, and there is poor molding of the head, because with increase in gestational age the head it becomes more hard and there will be poor molding of the head. And we have to give adequate analgesia to the mother. And we have to keep in mind that there is a possibility of shoulder dystocia, so we have to keep everything ready, anticipating shoulder dystocia. And fetal monitoring should be done with CTG, and prompt delivery by cesarean section or by forceps or ventos when fetal distress appears. So scheme for management of post maturity. First is fetal. We have to assess the gestational age properly. Then we have to do fetal surveillance by non-stress test, amniotic fluid estimation, BPP, and Doppler velocimetry studies. In uncomplicated cases, that is where you are doing expectant management, we can see if the cervix is ripe, we can just do stripping of membranes or ARM, and we have to see if the liquor is clear, then we can start oxytocin drip and expect a vaginal delivery. But if the liquor is meconium stained, we have amnio infusion and electronic fetal monitoring, and we can do scalp blood pH estimation. If the scalp blood pH is less than 7.2, that means it is there is fetal acidosis, so prompt cesarean section should be done. Whereas if it is more than 7.25, we have to just observe, and we have to do fetal surveillance, and we can expect a vaginal delivery. If the cervix is unripe, we have to do first ripening of the cervix with vaginal administration of PGE2 gel, that is Arviprime gel. We can repeat it every 6th hourly for maximum of 3 doses. If the cervix becomes ripe, we can do ARM, and if the liquor is clear, we start oxytocin drip, and if we look for vaginal delivery. If the liquor is meconium stained, same amnio infusion we have an option, and electronic fetal monitoring, and we do scalp blood pH estimation. If it is normal, then we can expect vaginal delivery. If there is fetal acidosis, we do cesarean section. In complicated cases, that is where we have seen there is history of hypertension or diabetes or oligohydramnias, or where there is fetal growth restriction. In such cases, there is inclination towards cesarean section, but if the cervix is favorable, we can try for vaginal delivery. For that, first we can do ARM and see for the LICA status. If it is clear, we can start an oxytocin drip, and we can see for vaginal delivery. If it is meconium stained, the same thing, we have to monitor, and we can do, if the facilities is available for scalp blood pH estimation, we can do it. And if it is normal, then we can look for vaginal delivery. Otherwise, we proceed with cesarean section. If the cervix is unfavorable in complicated cases, then we are more inclined towards cesarean section. Thank you.